see that the urinary system is intimately involved in this, but the lungs are going to be involved too. So we'll be taking that out as we go. So there's a lot to encompass on this next exam. Urinary system, fluid electrolyte, and acid-base balance. So this is going to be a big exam coming up.
Got this.
And so you need to really put in some time on this, because some of it takes a little extra effort to get to sink in sometimes. So I'm trying to make it, as easy to do that as possible. All right, so fluid, electrolyte, and acid-base balance. So let's take them one at a time. Fluid balance. Okay, so when we talk about fluid, we're talking about the fluid that's either within cells or bathes the outside of cells. Basically, that's what it is. Of course, there is some fluid in the bloodstream, plasma, but we'll talk about that. Water makes up about 50 to 60% of our body mass, and it's a diffusion medium for nutrients, metabolic waste, respiratory gases, hormones, lots of things, lots of things. Most of the water that we take in, most of the input is going to be via the GI tract. It's what we drink and the water in our food. But if you remember, we get a little bit of water from metabolism. Remember, from oxidative phosphorylation down the electron transport chain. A byproduct of that is water. So when we talk about metabolic generation, that's where we get a little bit of water from, but most of it's going to be what we take in. Okay? So as far as output is concerned, the kidneys are the main organs that help us to get rid of any excess water. And, speaking of the kidneys, I think we mentioned this before, but for the kidneys to be able to handle both nutrients and metabolic waste, these molecules and ions have to be in solution. Okay, the kidneys can't handle, dry stuff, solid stuff. It's got to be in solution. Okay, and so that's the main way that we lose fluid here. We lose a little bit in our feces. Now we also lose some water just by breathing, just by living, because we lose some water via water vapor by respiration. We also lose a little bit of water through our skin. So our skin is not waterproof, it's water resistant. So when we lose water that way, it's called insensible perspiration. It's called that because you're not really aware that you're losing it. And we lose that, as we said, by the lungs and by way of the skin. Now, we also lose some water by sweating. So when we're overheated, we sometimes sweat. And when that sweat evaporates, we lose heat via evaporation. So that kind of water loss is called sensible perspiration. Okay, so insensible perspiration is constant. We're always losing a little water that way. Insensible perspiration is variable because we're not always sweating. We don't need to sweat all the time. It's only when we're overheated. So if we put this in a diagram, this is what we would have. So most of our water intake is going to be what we ingest. And we produce a little bit by metabolic generation. Most of the water that we lose is going to be via the urinary tract over here. Now let's review our fluid compartments. The water in our bodies is either inside cells or it's outside cells. So if it's outside cells, it's extracellular. If it's inside cells, it's intracellular. Now, most of the water in our bodies is actually inside cells. The water that's outside cells is in various compartments of the body. So if we look at that, we can see we're looking at extracellular fluid here, and by the way, the abbreviation is ECF for extracellular fluid and ICF for intracellular. Plasma is mostly water, isn't it? So there's some water in our blood vessels in the form of plasma. The fluid that bathes the outside of cells is called interstitial fluid. So that's fluid that bathes the outside of cells. We also have some fluid that's called compartmentalized fluid. So that means it's fluid in fixed spaces, like the cerebrospinal fluid that we have, joint fluid, the little bit of serous fluid around the heart and around the lungs and around the intestinal tract. So all of that makes up compartmentalized fluid. So if we looked at a diagram of that, this is what we would have. Intracellular fluid here, extracellular fluid over here. So extracellular fluid is going to be composed of interstitial fluid and intravascular fluid, or the plasma. Now, as far as clinical problems with fluid balance go, we're mainly talking about ECF and ICF to the exclusion of compartmentalized fluid. So if we have fluid shifts that cause clinical problems, we're not considering compartmentalized fluid in that. That's fairly fixed and stable. The clinical problems come from imbalances between extracellular and intracellular fluid, as you see right here. This is just another way of expressing fluid compartments and the way fluid and nutrients and metabolic waste move back and forth. So with the lungs here, you can see we're taking in oxygen that goes to cells for cellular metabolism, and we're giving off CO2, which the lungs get rid of. Our nutrients come from what we ingest for cells to use. So that's going this way towards cells. Now these other nutrients here, water and ions, there's a back and forth movement of those. Over here in our kidneys, there's a back and forth movement of water and ions. And of course, metabolic waste, in large part, are going to be eliminated via the kidneys. Now, we remove some nitrogenous waste and other things via the feces, but mainly we're handling the removal of these things via the kidneys and the lungs as far as respiratory gases are concerned. This is just another way of stating this, and you're well familiar with this by now. Now, so as we said, most of our water is intracellular, so about roughly 2/3 of our body water is intracellular, about 1/3 is extracellular. Now, within these two compartments, the principal ions are different. So in extracellular fluid, the principal ions are these: sodium, chloride, bicarbonate, and calcium. In intracellular fluid, the primary ions are these: potassium, magnesium, and phosphate. That's not to say that there's not some of both groups in the other compartments, because there is. It can be. But the principal ions for those two compartments are those. Now, here is a principle. The composition of extracellular fluid is different from the composition of intracellular fluid, largely because of this. You see? In other words, take, for example, sodium. Sodium is principally an extracellular fluid ion. Potassium is principally an intracellular fluid ion. Does that mean there's no potassium in extracellular fluid? No, it doesn't, because there is. When you have your blood tested, you check for your electrolytes. One of the things they check is potassium, right? Don't they find some potassium in your blood? Yeah. But the thing is that the cell is constantly pumping most of the sodium back out in exchange for potassium, which goes into the cell. There's phosphate inside cells mainly. It's a main intracellular ion. Is there phosphate ion in blood? Yeah, in extracellular fluid, sure. Yes. All right, but anyway, the composition is different in the two compartments. Now, why is that? Because the cell membrane is a selectively permeable membrane. In other words, things cannot go back and forth willy-nilly across the cell membrane with no order or organization or control. So it's a selectively permeable membrane. This is why we have ions that are principally found in extracellular fluid and some that are principally found in intracellular fluid. So we've got active transport mechanisms in this membrane that account for this. But, here's the big but. The osmotic concentration in both fluid compartments is normally the same because of water movement across the cell membrane. Water movement by osmosis is a totally passive process, and the movement of water is actually controlled by the composition of intracellular and extracellular fluid, as I will show you in a bit. All right, so just remember that the composition of the two fluid compartments is different, but the osmotic concentration in the two compartments is or should be the same. So there's a continuous back and forth fluid movement between ECF and ICF, and by fluid we mean water. And this is regulated by two different kinds of pressure, by hydrostatic pressure and osmotic pressure. Water moves freely and passively between the two compartments along osmotic gradients, as we shall see. Now, a change in concentration, in solute concentration in either compartment is going to lead to net water flow across the cell membrane. So, for example, if we increase the solute concentration in extracellular fluid, the volume in intracellular fluid is going to diminish because fluid is going to come out of cells into extracellular fluid. Conversely, if we have a low solute concentration in extracellular fluid relative to the solute concentration in intracellular fluid, water is going to flow the opposite way. Water is going to flow out of extracellular fluid into cells. So this is, go back to the definition of how water moves by osmosis. From an area of higher water molecule concentration to an area of lower water molecule concentration. But you can look at what we just said here and say, you could say it a different way. Water will flow from an area of lower solute concentration to an area of higher solute concentration. It produces the same thing. You're just thinking of it in terms, one way, of water molecule concentration, and the other way, solute concentration. So the bottom line, intracellular fluid volume is determined by extracellular fluid concentration. That's the bottom line on that. Now, can we measure water gains and losses in our body directly? No, not directly. We can monitor indirectly because we have receptors that monitor these changes in order to maintain homeostasis. So let's look at a couple of areas here. As far as plasma volume is concerned, if we have a drop in blood pressure from low blood volume, how does the body react to that? Well, we have baroreceptors that we talked about, right? A drop in pressure, we're going to get an increased rate of heart contraction and force of heart contraction and peripheral resistance to bring the pressure up, aren't we? That's going to be mediated through the medullary centers for heart and peripheral blood vessels, correct?
Yes.
We talked about that. We also have that system in the kidney, the juxtaglomerular apparatus, that, remember, that monitors the rate of flow of tubular fluid and the solute concentration of that fluid. So if blood pressure and blood flow to the kidney drop, isn't that going to mean that the glomerular filtration rate in the kidney drops too?
Yes.
It will. And if you're not filtering as much plasma, isn't that going to mean that you are producing less tubular fluid?
Yes.
And so the juxtaglomerular apparatus is monitoring the rate of flow through the distal convoluted tubule as it comes up next to the renal corpuscle. So it's monitoring a low flow rate. Now, if the rate of flow of that tubular fluid through the convoluted tubular system slows down a lot, isn't that going to give more time for solute to be absorbed out of that fluid into renal tubular cells?
Yes.
So this means that that slow-flowing fluid that's coming past the juxtaglomerular apparatus is going to have a slow rate of flow and a lower solute concentration than normal, right? So what's the kidney going to do in those cases? It's going to release some renin from those granular cells, and it's going to set in motion the renin-angiotensin system. If it's a severe drop, if it's not severe enough to initiate that, it's just going to affect those mesangial cells and open up the afferent arteriole and constrict the efferent arteriole and increase the filtration pressure as well as the flow, right? And you'll bring your glomerular filtration rate back up. So we're monitoring the plasma volume then, aren't we, in those ways. Here's another way. By constant measurement of the osmotic concentration of the blood. The hypothalamus contains tiny osmoreceptors that are constantly monitoring the solute concentration of the blood, which we know as the osmolality of the blood. When the osmolality of the blood goes up, that means there's a relative deficiency of water in the bloodstream, right? And so when that happens, the hypothalamus triggers the posterior lobe of the pituitary gland to release antidiuretic hormone. Antidiuretic hormone acts on the collecting ducts of the kidney to increase water reabsorption. They also have it also has a little effect on the distal convoluted tubule also to increase water reabsorption. All right? So if we reabsorb water in this condition, shouldn't our solute concentration in the blood go back down toward normal as we're recovering water to dilute that solute concentration, correct?
Yes.
So when that happens, the hypothalamus cuts off the stimulus to the posterior lobe of the pituitary and shuts off ADH until such time as it may be needed again. So an example of this would be in dehydration. So a person who is severely dehydrated has lost water from plasma volume, right? So the solute concentration or osmolality goes up, doesn't it?
Yes.
Hypothalamus notes this. First of all, you get thirsty, don't you? When you're dehydrated, you're thirsty. So it stimulates thirst. through its thirst center, the hypothalamus, and it simulates this mechanism of release of antidiuretic hormone, which causes the kidneys to recover water from the filtrate. All right, just some definitions here. We're talking about osmolality. Osmolarity and osmolality are two closely related terms. Osmolarity just refers to the total concentration of all solute particles in a solution. Osmolality is the number of solute particles dissolved in a certain volume, like in 1 liter of water. And it reflects the solution's ability to cause osmosis. The solute concentration of blood is measured as its osmolality. The normal osmolality of blood is 295 milliosmoles per liter. Now, when we were talking about the kidney, and we were talking about what happens in the loops of Henle, we showed you the little diagram of the filtrate having an osmolality of 300 milliosmoles as it headed down
1,200.
away from the renal corpuscle. We just rounded off 295 to 300, just so it's easier to talk about in even numbers. All right, let's again review how water moves. So what is the term for water movement?
Osmosis.
Osmosis. It's actually diffusion, isn't it? But with water, we just call it osmosis. So when you talk about osmosis, you're strictly referring to water, not anything else. All right? And we talked about the way that water moves, didn't we? From an area of higher water molecule concentration to lower. You can also think of it in terms of solute, but it moves from an area of lower solute concentration to an area of higher solute concentration. All right. Again, just stressing that solute concentration inside and outside cells determines which way water moves. Sodium concentration in extracellular fluid gives huge clues to which way water is moving.
Does water follow
Right.
sodium?
Sodium is the most important cation in extracellular fluid. So if we have problems with water movement, most of the time it's going to involve sodium. So again, we're just stating in a different way what we showed earlier. If the sodium concentration is higher than normal in extracellular fluid, water will move out of cells into extracellular fluid. If we have the opposite condition of it being lower than normal in extracellular fluid, water will move into cells from extracellular fluid. And you can apply the definition of how water moves here by either of the two ways we talked about osmosis. Here's another way of looking at it. If we lose water from extracellular fluid, water is going to move out of cells. So the interior of these cells is going to be underhydrated. On the other hand, if we add water to extracellular fluid, water is going to move into cells, isn't it? So look at your definition of how water moves. In this case, solute concentration goes up, doesn't it? And pulls water out of cells. Down here, look at it in terms of water molecule concentration. If you add water to extracellular fluid, which way is water going to move? It's going to move into cells, isn't it? Because you're changing the solute concentration when you add water to extracellular fluid. You're lowering the solute concentration. But you have a relatively higher than water molecule concentration out here than you do here, so water is going to move into cells. Here's another way of looking at it. These are red blood cells. So that looks like a fairly normal red cell, doesn't it? All right. What do we know about this cell? We know that the osmotic concentration on both sides of the cell membrane is even. All right, because this is a nice, healthy looking red blood cell. So in this condition, the solute concentration in extracellular fluid and intracellular fluid are equivalent. This is a normal condition, and we refer to this as being isotonic, meaning the same tonicity on both sides of the cell membrane. Now, look at this red cell. It's shrunken up, isn't it? It's what you call crenated red cell. Now, what caused this?
The release of fluid.
More water on the ECF.
The solute concentration in extracellular fluid was higher than the solute concentration in here. It pulled water out of the cell. All right? So the cell shrinks up. Now, we call this condition hypertonic or hypernatremic. The NATR stands for sodium ion. So hypernatremic means too many sodium ions, and so water is moving out of cells into extracellular fluid. Now, look at this cell. This one's bloated, isn't it? All right. Now, what happened here? We have a lower than normal solute concentration out here compared to here. Or we have a higher water molecule concentration out here than we do here. So water moves into cells. All right? So this condition is called hypotonic or hyponatremic.
Hey, Professor, how much water would you have to drink for your blood cells to do that?
A lot. A lot. In fact, drinking enough to cause this is, that's a pathologic condition here. You may remember back a few years that there was a woman who died from water intoxication.
Yeah.
She kept drinking water. What was the reason for that? I can't remember. But she drank to her death.
There was a couple years ago, there's a little girl whose parents made her drink a bunch of water, and it killed her.
Right. If this is happening to red cells from this, what do you think is happening to brain cells?
Ooh, they're swelling like crazy.
Right. All right. So let's move on to electrolyte balance. What in this world are electrolytes anyway?
They're in Gatorade. That's all I got.
Well, you're going to see that these electrolytes are actually various minerals with a charge, aren't basically what they are. So they are soluble compounds, mainly inorganic compounds, that are present in both extracellular and intracellular fluid that in solution will dissociate into their respective ions. And in so doing, they're capable of conducting an electrical current. Another thing about them is that they contribute to the osmotic concentration gradients in solution. Okay. So for example, sodium chloride in solution dissociates into sodium ions with a positive charge and chloride ions with a negative charge. Right. The water molecules have an attraction for sodium ions and pull. See, oxygen in water has a slightly negative charge in solution. and the hydrogens have a positive charge. The slightly negative charge pulls sodium away from chloride in solution, dissociates like that. So you express their concentrations in milliequivalents per liter. Well, what's a milliequivalent? How do you come up with milliequivalents per liter? Well, this is the way to do it, although you don't have to necessarily remember this, but let's just take sodium as an example. All right? So here's our formula to determine milliequivalents per liter. We put the ionic concentration of the substance over its atomic weight and multiply by the number of electrical charges on one ion. So let's just say that the concentration of sodium in a solution is this, 3,300 milligrams per liter. This is the atomic weight of sodium down here. And of course we know that sodium has one charge. So if you work this out, you come up with this, 143 milliequivalents per liter. That's the normal concentration of sodium in human blood. Now there's a range, of course, you know, I didn't have to take it right at 143, but there's a range, you know, around 136, 137 up to 145 maybe, the most. Okay, so there's a range in there. You go to have your blood drawn in the lab, you do a chemistry profile. They're always going to measure sodium, chloride, potassium, bicarbonate, BUN, blood urea nitrogen, creatinine, things like that. All right? And the numbers that you see for those determinations are in milliequivalents per liter for these ions here, these electrolytes. Okay. Now let's say that somebody has a sodium concentration of 152 milliequivalents per liter. What's that going to tell you about the state of water balance in their bodies?
Higher salt.
Well, yeah, the sodium is high. It's above the normal range. Okay, the normal range is going to be 152 is well above this normal range. All right. So let's say your sodium concentration is 152 milliequivalents per liter in some person here. What's that telling you about water movement in their body?
Dehydration. Dehydration.
That's not
Dehydration of what?
the inner cell.
The cells.
Yeah. Right.
Because this sodium of 152 is going to pull water out of
the
cells, isn't it?
Yeah.
It's going to dehydrate cells.
Uh-huh.
All right. Now, what if this number here was 130 milliequivalents
The
per
cells are
liter?
going to be swollen. They're going to be overhydrated.
Which way is water going to move now?
Into the cell.
Into cells.
Right.
Right. Now, these electrolytes, as you'll see here, and as we indicated, are present in both extracellular and intracellular fluid. But as you will see, that, remember we said before, certain of them are principal ions in extracellular fluid, certain of them are principal ions in intracellular fluid. But you're going to see that they're present really in both compartments. So take a look here at sodium. What does this tell you? It's principally an extracellular electrolyte, isn't it? Is it present inside cells? Look at your key. Yes, a little bit. Whereas potassium is mainly an intracellular ion. Is it present in extracellular fluid? Yeah, a little bit. Calcium, mainly extracellular. Magnesium, mainly intracellular. Bicarbonate, both, but mainly extracellular. Chloride, of course, is going to follow sodium. Phosphate, as we said earlier, is mainly an intracellular ion, but yeah, there's some in extracellular fluid. sulfate, mainly intracellular. Now, look at these protein anions. Don't we have proteins inside cells and proteins outside cells? All right. When you look at diagrams of the cell membrane, you will see when the charges are on there, you will see that the negative charges are on the inside of the cell and the positive charges are on the outside of the cell membrane. Isn't that correct?
Mm-hmm.
Why is that? It's because of the protein anions. The proteins inside the cell have commonly acting as buffers, and so they're giving you a net negative charge inside the cell. This is why the interior of the cell is negative relative to the outside of the cell, which is positive. All right, so the most important cations, what's a cation? An ion with a positive charge are these. The most important anions, of course anions would be ions with a negative charge, are these, right here. Now, I didn't tell you that with water balance, our gains need to equal our losses. Does that make sense?
Yes.
With electrolytes, our gains need to equal our losses to keep an electrolyte balance. Okay? When we talk about electrolyte balance, we're mainly talking about the salt balance in the body. Remember I told you sodium is the most important cation, and that's what this is saying right here. The main determinant of salt balance, and therefore the osmotic gradient, is this ion right here, sodium. So, as we noted, sodium concentration in blood can be easily measured with a blood test. And it gives a very good indication of the state of hydration. Again, to, I guess, not belabor the point too much, but total electrolyte concentration directly affects water balance through water movement by osmosis. And this is another way of saying what we've said before. If you increase the sodium concentration, of course it'd be sodium chloride since they move together, in extracellular fluid, water's going to move out of cells into interstitial fluid and blood. And the opposite if we drop the sodium concentration. That's why I was giving you those examples of the sodium of, say, 152 versus the sodium of 130 milliequivalents per liter. Now, abnormal concentrations of individual electrolytes affect cell function. So here are just some examples with just potassium and sodium. So if we increase the concentration of potassium ion in plasma enough and significantly, we run the risk of increasing irritability of the myocardium, which produces abnormal rhythms, could produce a bradycardia, even can produce cardiac arrest.
Is that when they do open heart surgery, don't they actually pour potassium into the heart to stop it?
I don't know whether they do or not.
Okay.
But this is why you never give potassium IV push.
Okay.
If somebody has a low potassium, you supplement it in a drip.
Okay.
Because if you give IV potassium push,
Causes a shock.
you can cause this.
Okay.
You make the heart stop.
I thought I remember I was watching open heart surgery. They did like a live one on, well, it was on YouTube, so it wasn't live anymore. But I thought I remember them like funneling potassium into it to actually stop the heart while they worked on it.
Yeah, well, maybe they do. I don't know.
Okay.
All right. Conversely, if the potassium level in the blood drops, you can also affect the heart. Not necessarily making it stop, but you can make it weak. So you can produce weak contractions and also abnormal rhythms. With sodium, we've talked about what sodium does. If you increase the sodium concentration in extracellular fluid significantly, you can dehydrate cells. And if you've got too low sodium, you can essentially overhydrate the cells. So looking at sodium then in review, it's the dominant cation in extracellular fluid. It has a low concentration in intercellular fluid, as we've seen. Most of the problems, as we've mentioned, with electrolyte balance are with sodium. Blood pressure and blood volume are very much linked to the sodium-water balance. And remember this axiom right here, water follows salt. Now, why is that? Why is this axiom true?
Let's do the oxygen in the water.
If you're moving sodium out of extracellular fluid,
concentration is heavier.
out of blood,
Yeah.
okay, you're changing the osmotic gradient in blood, aren't you? And water is going to want to follow salt
Yes.
in order to maintain an even osmotic gradient on both sides of the cell membrane. Here's the normal plasma concentration. It may vary a little bit, a milliequivalent or two, depending on what lab you're talking about, but it's somewhere in this range right here. Now, how do we regulate sodium and fluid movement related to sodium in the body? Well, minor changes, day-to-day operation, operate the way we mentioned earlier relative to the hypothalamus. Okay, so the hypothalamus is constantly monitoring the osmolality of the blood. And so little variations, and it's very sensitive, little variations, it just turns ADH on or off, depending. And if we are slightly dehydrated, we recover more water from blood, from the renal filtrate, and so forth. This is what happens just in normal day-to-day living.
Okay.
Now, major changes relative to sodium occur in major insults to the hemodynamic status in the body. So if we've got a major drop in pressure or circulating volume, we're going to be resorting to the renin-angiotensin II system. And sodium is going to be very much involved in that, isn't it? Via aldosterone, because aldosterone causes sodium reabsorption, and water follows it. Potassium is the main cation of intracellular fluid. It has, as we saw, a low concentration in extracellular fluid. Problems with potassium are far less common than problems with sodium, but they're more dangerous than sodium. Potassium balance is accomplished mainly by how much is secreted into tubular fluid. All right? As we reabsorb sodium, we tend to exchange potassium for it. So as we take sodium in, we usually are secreting potassium to keep the electrolyte balance in the body. So the main hormone that's involved with this is aldosterone. So, for example, if we have an elevated potassium level in blood, that's going to trigger the release of aldosterone from the adrenal gland. Aldosterone is going to cause sodium reabsorption and potassium secretion. The normal plasma concentration of potassium is somewhere in this range right here. It could, depending on what lab you're talking about, could vary a milliequivalent or two. Too much potassium can cause these kinds of problems here. We saw its possible effects on the heart. Too little potassium in the blood can cause these problems. And then it can cause problems with the heart as well. Now, here are some causes of hyperkalemia. Hyperkalemia means higher than normal potassium levels. Hypokalemia means lower than normal potassium levels. So you'll need to be aware of these. Usually ask something about this on exam. But let's go over these. What can cause too much potassium in the blood? Well, if the kidneys aren't working. Okay. So if there's renal failure, potassium levels are going to tend to rise. Okay. Hypoaldosteronism. Okay. What does aldosterone do? Causes sodium reabsorption and potassium secretion. If we have a deficiency of aldosterone, we're not reabsorbing potassium, therefore we're not secreting, we're not reabsorbing sodium, therefore we're not secreting potassium, so levels in the blood go up. We mentioned this one, rapid intravenous infusion of potassium. Severe soft tissue injuries like massive burns that destroy lots of cells and release potassium into the bloodstream really create hyperkalemia. A drop in pH. What does a drop in pH mean?
An increase.
That you have an increase in hydrogen ions in blood. All right. When that happens, some of those hydrogen ions tend to go into cells in exchange for potassium ions, which come out of cells into the blood and cause blood potassium levels to go up. Here are some causes of hypokalemia. Obviously, if you don't have enough in your diet, diuretics will do it. People who are treated for congestive heart failure, say with some preparation of digitalis and a diuretic, will typically be given a potassium supplement of some kind. Okay, so diuretics can wash out potassium. Hyperaldosteronism, which is the opposite of this, isn't it? So if you've got an overactive adrenal gland that's producing lots of aldosterone, you're absorbing extra sodium and getting rid of too much potassium. So that can do it. Losing it by way of the gastrointestinal tract, okay, by vomiting or by diarrhea or even suction tube. People lying up in the hospital with a nasogastric suction in, they're being supplemented with intravenous fluids, and usually they have a, supplement of potassium as well.
Could that be why? Could that be one of the reasons why pregnant women wind up having lower potassium levels because of morning sickness, things like that?
I don't know if that would be enough to cause it. Yeah, I guess it would happen. But usually if it's just happening, periodically in the morning like this, I don't think that's probably going to
Be enough to.
be enough to cause a problem.
Okay.
Now, an elevated pH, what does that mean?
Eat your alkaline.
The opposite, you have
Yeah.
a lower than normal hydrogen ion concentration, right? In those cases, you have the opposite to what you had here, right? Okay. So, some of the hydrogens are coming out of cells in return for potassiums that are going into cells. Creates the opposite condition here. All right, moving on to calcium. Calcium is a very important electrolyte. It has many functions in the body, doesn't it? And we've already talked about, some of you know about its importance in skeletal cardiac muscle function. You know about its importance in blood clotting. And it has these other functions too. Cell membrane permeability, sometimes it's a cofactor for enzymes. It's a second messenger for certain hormones. I know we haven't talked about that yet, but it is important in that respect too. We reabsorb most of it through the proximal tubule. this is its normal concentration here. Normal blood levels of calcium are maintained primarily by parathyroid hormone. Parathyroid hormone operates when calcium levels are too low. All right? And these are the ways that parathyroid hormone maintains calcium levels in the normal range. We talked about these in lab right here. Now, too much calcium, too little calcium. These are some of the causes of hypercalcemia. Calcium levels too high. Hyperparathyroidism. That will certainly cause it one. Vitamin D excess will cause it. Prolonged immobilization will cause it. You have somebody who's very sick, long-term, paralyzed person lying up, their bones are going to demineralize because they haven't been stressed. Okay? Renal disease, obviously, will cause. The main problem with hypercalcemia is decreased neuromuscular excitability. So think of this in opposites. Hypercalcemia causes decreased neuromuscular activity, as compared with hypocalcemia, which causes the opposite, increased neuromuscular excitability. What are some causes of hypocalcemia? Well, look at these and then look at these. Hypoparathyroidism, vitamin D deficiency, of course renal disease will cause it too, alkalosis will cause it, hyperphosphatemia, diarrhea. All right, moving on. Chloride. Now, chloride is going to move with sodium, isn't it? So it's the most abundant anion in extracellular fluid. It's absorbed by the digestive tract and the kidney. Daily loss is small. This is the normal range for its concentration. Right. Remember we talked about how things move across the cell membrane, and we said one of the ways through these protein carriers and channels is by counter transport, that you have two things moving in opposite directions at the same time across the cell membrane. Chloride typically moves with bicarbonate ion. So when bicarbonate is moving one way across the cell membrane, chloride is typically moving the opposite way. This is a classic example of counter transport.
That's what's going on in the alkaline tide when we're in digestion, right?
Exactly.
Okay.
The alkaline tide in
chloride's
digestion
coming in.
is an example of this, and you will see some examples of this in the kidney,
Okay.
in the way things move across the tubular cell membrane.
Okay.
Phosphate. Phosphate is a mainly intracellular ion, isn't it? All right. Now, it has some important functions, doesn't it? Synthesis of ATP. Remember inorganic phosphate? You can't make ATP without inorganic phosphate, can you? All right. Synthesis of nucleic acids. When we get to talking about DNA and RNA, you're going to see that there are some important phosphate bonds involved here. So, very important. Now, phosphate is mainly an intracellular ion. So it's an intracellular buffer, for example. But it is also an important extracellular buffer because it acts as a buffer in renal tubular fluid, as I shall show you later. All right, so although it's mainly an intracellular ion, it has an important use as a buffer outside the cell, and specifically in renal tubular fluid. All right, let's look at some regulatory hormones of fluid and electrolyte balance. We've been talking about antidiuretic hormone, haven't we? All right, now, where does antidiuretic hormone come from? Posterior lobe of the pituitary. What controls its release from there? Hypothalamus. Where does it act? On the kidney. Where in the kidney does it act? Collecting duct. All right? So, when we have situations where the osmolality of the blood is increased, in other words, an increased solute concentration of blood, which is primarily due to what ion most of the time?
Sodium.
Sodium. All right? Remember that we talked about the osmoreceptors in the hypothalamus that are constantly monitoring the osmolality of the blood. So, if we have an increase in osmolality, the hypothalamus is going to stimulate the posterior pituitary to release antidiuretic hormone. Antidiuretic hormone is going to act on the collecting ducts of the kidney, and it's going to cause water reabsorption. Antidiuretic causes the insertion in the cell membranes of the collecting duct of some proteins called aquaporins, which are conduits for water movement out of the collecting duct into the collecting duct cells and thence into blood. So as we reabsorb this water, what happens to the solute concentration of the blood? It goes down, doesn't it? And when it gets to the normal level, the hypothalamus cuts off stimulation of the posterior lobe of the pituitary. So you see the negative feedback right here? Right there. Now, in profound hypovolemia and hypotension, ADH is a vasopressin. Vasopressin is its other name. It primarily acts to constrict visceral blood vessels. But this is not its most common role. Okay? Its most common role is what you see right here. Aldosterone. We've been talking about this hormone, haven't we? All right. Now, where does this hormone come from?
Adrenal
The
gland.
adrenal gland. In the cortex of the adrenal gland. We'll talk a little bit more about this later. But what triggers the release of aldosterone from the adrenal cortex? If we have an elevated potassium level or a low sodium level, either one of those will trigger aldosterone release from the adrenal cortex. All right. So this is what's happening, as I mentioned, in our just normal living, day-to-day operations. Got little minor variations here, easily taken care of here. But you notice that in severe insults to the body, the renin-angiotensin mechanism, which has multiple effects, one of which is with aldosterone, isn't it? So anyway, the adrenal cortex releases aldosterone. Where does it act?
Tubules.
It acts primarily on the renal tubules, doesn't it? All right. What does it do?
It's going to reabsorb
Causes
that.
sodium reabsorption and
Potassium
potassium
secretion.
secretion. All right. And we restore our normal balance. And when that happens, the negative feedback is on the adrenal cortex to cut off aldosterone. Now, as we are reabsorbing sodium, what's happening to water?
It's going with it.
It's moving with sodium. Isn't it? Now, let's say that we had a situation where there was profound insult to the hemodynamics of the body. massive blood loss, drop in pressure, drop in circulating blood volume. What system is that going to trigger?
Sympathetic.
The renin-angiotensin system, right? And angiotensin 2, remember, is a potent vasoconstrictor by itself. But it also causes secretion of aldosterone by the adrenal gland, as we just saw. It's going to cause the secretion of antidiuretic hormone from the posterior pituitary. It's going to increase thirst, right? And by those various mechanisms, along with whatever else the medical personnel will do to help correct the situation, we're going to try to restore blood pressure and circulating blood volume to a normal level. All right, let's say we're successful at that. All right, we found out, what the problem was. May have required some surgery, remove a ruptured whatever spleen. But let's just say in the process of resuscitation, the system was overloaded with fluid and possibly with sodium. So now we've got a fluid overload relative and maybe an elevated pressure, blood pressure. We want to get that back to normal. This hormone is what does this. All right? So as we correct a hypovolemia and hypotension of profound proportions, don't we increase the volume of blood returning to the heart?
Yes.
We increase venous return, don't we? As you increase the volume returning to the right atrium, it stretches the atrium, doesn't it? And there are stretch receptors in the atrium that will release this hormone right here, atrial natriuretic peptide. You see how sodium is involved in here? In ATR, stands for sodium. All right, what's this going to do? Well, you've got an increased venous return, stretch receptors in the right atrium, releases this hormone. The easy way to remember what this hormone does is that it does just the opposite of what angiotensin 2 does. It cuts off angiotensin 2, and therefore it will cut off aldosterone, it will cut off ADH, and try to stabilize the situation. Now, but our problem was that we've overcorrected the fluid volume, and maybe we're overshooting our blood pressure. So what do we need to do in this case? We need to get rid of some extra circulating fluid, don't we? All right, so we call on the kidneys to do this. So how does ANP help us do this? Well,